Hello and welcome to the Bee's Knees podcast. This is your host, PJ Ewing. Today we have a lengthy interview with a physical therapist named Michelle Stiles. I came across Michelle through some of her outbound work on Twitter and YouTube, and then I visited her website and I learned about what she does, and I just really wanted her on the podcast as soon as possible, and we did that soon enough. And now we can share that with you today. It's a little over an hour, so sit down and get a comfortable chair and a cup of coffee and maybe a notepad because there's some great insight here. I also want to point out that there are some very important links to content that we talk about in this interview that are placed in the show notes on this podcast, or if you just go to the episode webpage, you can find those links as well. You will want those links. You'll want to write them down or click on them and store them because there are some tests that you may consider taking. There's some evaluations that you may want to do. This is really about what is your condition? Do you need knee surgery? Can you avoid knee surgery? Can you put it off? How do you put it off, particularly if you're at a younger age? Michelle will go into some real detail about why it's advisable and how you can avoid it, but why it's advisable to potentially put off surgery if you're in your late 40s or early 50s and how one does that. And also, if you can predict your likelihood of needing a knee replacement or other knee surgery, there are some markers and some tests that can be done that Michelle takes us through that you will find extremely interesting. I really think this is a great episode for those that are under 55 years old who would rather not go through a total knee replacement quite yet, or maybe ever. So this is a good one. Get comfortable, be ready to take some notes, or just afterwards, click on the episode webpage and visit the site where you will see some important links that sort of support the conversation that we're having.
Welcome to The Bee's Knees, a podcast full of articles, interviews, clinical studies, and advice about knee surgery, physical therapy, and life after knee surgery.
Hello, everyone. This is PJ, and I am really excited here today, right now, to have Michelle Stiles, a physical therapist, with us. Hi, Michelle. How are you?
Hi, PJ. Nice to be here with you.
It's early, right, where you are?
It is early.
Tucson.
I've had my second cup of coffee and had a bracing walk of my dog so that I'm awake and alive and ready to chat.
Well, what time did you get up this morning?
4:45.
Good Lord. It had to be. I'm in the east, you're in the west.
Right, you kind of start to do that when you live in Tucson and the big ball of sun comes up, and you know, in order to get some outside time in the summer, you really need to get up early. So it's just sort of a habit.
Wow. What kind of dogs do you have?
Yeah. Little cockapoos.
Nice.
They're great little dogs, yeah.
Yeah. And they're quiet. They were barking earlier before this call started.
I know.
Speaking dulcet tones. We want to wake them up.
That brandy was great.
Oh, God. All right. Well, we're here to talk about Michelle and the work that she does. I'm very excited to have you on the call. I was observing some of your work on YouTube, and I became aware of your blogging and just your communication, and I was, interested immediately because it seems to me that, and I don't want to put words in your mouth because you're going to get a great chance to talk all you want, but that we have an opportunity to actually, with Michelle's help, completely avoid, in some cases, avoid having to do knee surgery, avoid knee replacement. There are, for those that are potentially in the right circumstance, there are diet, inflammation, knowledge, the exercises, programs that one can adopt to just not put the pressure on the knees, avoid osteoarthritis, and maybe just skip this whole knee surgery and recovery thing altogether. The Bee's Knees is about knee surgery and recovery, but we're going to maybe shortcut everything that we talk about in this little podcast and maybe be able to avoid it with Michelle's help. So that's my little thought that we can put a pin in that. But let's get into your background, what you do. Take us a little bit back and tell us your story just a little bit.
Well, I've been a physical therapist for over 25 years. I got into it and was very, very fortunate to work with a outstanding orthopedic surgeon early on in my career. He was on the East Coast in Virginia Beach. His name was Dr. Louis Jordan, in the Jordan Young Sports Institute. He was really a pioneer, and at the time, he, was still early going in those years. I mean, they were just sort of, it was going into full swing, let's say, and but he was really had a lot of foresight. He was I believe he was from Cornell or Colgate, an old basketball player, and he very much took care. It was very a paternalistic sort of practice. He realized that rehab was such a big part of it, especially back then because people didn't get their knees done right away, right? Because this was still kind of an odd thing to do, and so their range of motion was much more abbreviated, and they had profound weakness in many cases. So the rehab was a lot different back then. And so he realized that, if he didn't make the rehab go smoothly for his patients, it didn't matter how good a surgeon he was. You know what I mean? If the rehab screwed up his surgery, there wasn't going to be a good outcome for his patient. And then he would have, an excellent outcome was a walking marketing tool for him, right? So he understood that right away. And he actually came to the home health agency that I worked for and instructed us on what he wanted done with his patients, which is, I've never had that happen again. But he's one of the first that advocated doing the exercises 4 times a day in that frequency level. And as a young PT, I thought, I think that's a little bit too much, geez, can my 80-year-old lady do that? And should I be suggesting that? And as I, worked with him longer, I was like, wow, I was just blown away. And then I added some things of my own, and that's the system that I ended up created, and then the book that I ended up publishing. And I thought, I just want to get this out there to people because, after I finished working with him, and then I worked with another pretty top group in New York, I went on the road, and I found out that, wow, there are a lot of gaps out here. There are people that are not getting something that I think is just like I thought everybody knew this. And, again, earlier on, before I had that experience, when, there's a basic set of exercises that we give everybody. And generally speaking, we'll go, well, if somebody doesn't do well, it's on the patient. That's kind of the default in therapy. So, well, they're not really doing them. They say they're doing them, but they're not. But what I really found out is that, when we have them measure, and one of the things that I did was change degrees to inches. So I created, a way for them to measure their progress session by session so that they weren't just treadmilling. And, what would happen was it would get stiff, and then they would stretch, and they would get back to that same point but no further, and then they would stretch again and go back to that same point but stretch. So they were actually doing the exercises, but they weren't effective for them. Anyway, so we tried, fix that, and again, I put, different pieces of this puzzle together, and as I had a lot of time, with people in the home, and I think that's another benefit of the track that I pursue, kind of outside the clinic, it allowed me to be one-on-one with people, figure out what didn't work for them and why they didn't succeed, and then, when I did get kind of the system down between Dr. Jordan's stuff and mine, I was like, wow, this really goes easily. And I was kind of amazed, because even 84-year-old women, it's like, I could tell you would make, if you would follow this system, you would increase 2 to 3 degrees per day. And now, for somebody, I'm kind of a go-getter, and I think, geez, it doesn't sound like very much. And when you show somebody 2 to 3 degrees on a goniometer, that little tool that you measure angles with, you go, wow, that's not very much. I'm doing all this work. But when you put 2 to 3 degrees together for a week and you get 21 degrees range of motion, it's phenomenal for people.
It's a huge week.
And
a huge week. Yeah, that's amazing.
Yeah. So, they would just, and I could just track it. I said, now, I would go into a patient on Friday, so now if you continue to do this, you're at this amount here, 2 or 3 degrees, so you should be here by Monday. And we'll check that. And they were. And so that's why I put it out there, the little book.
So wait a minute, is that this Fast Track Your Recovery from a Total Knee Replacement? That's the book we're talking about, right?
Right.
Okay, and so it's all in there, the protocol that you described, that you refined from Dr. Jordan, the work that you did. Is it turn out to be 4 times a day? Can you tell us a little bit more about it?
Yeah, it is. The frequency is 4 times a day. And the reason for that is everyone who has a knee replacement will say the morning stinks, right? You get up, you feel like it's Groundhog Day, that movie.
Mm-hmm. Yeah, sure.
Bill Murray,
Bill Murray.
And I got to start over again, and my knee feels like, garbage. And so what happens is over the night you're not moving, right? And the swelling comes back in that knee, and then you do the bending exercises, and you get back to square one first thing in the morning. Then the second section you can move off that mark and make some progress. The third session a little bit more. The fourth session, sometimes people are a little tired, but if at least maintained, you don't fall back. You know what I mean? And you start making progress through the day. When you do this 8-hour, like maybe twice a day thing, or even 1 time a day is worse, then you basically will get back to baseline. What you're doing is you're swelling the knee, the fluid's kind of creeping back in, you'll drive it out, you'll get back to that, let's say, wherever you were, and then you'll wait 8 hours, the fluid comes back, you drive it out again, and so there's this sort of plateauing treadmill, getting stuck type effect that happens when you do low frequency.
So frequency is really key to this thing. It totally does. So frequency is key. Yeah. Big thing. 4 times a day. And how long are the sessions? And are you doing, quad sets and heel slides, or what are you doing?
Yeah, they're not. The sessions aren't very long. They're maybe 20 minutes to 30 minutes by the time you put the icing and elevating. But here's another key: is that there's 3 phases. You work on range of motion first, then you work on and a baseline strength, a basic strength, and then you focus more on strengthening, and then you focus on body weight functional mobility. Mm-hmm. And if you do that, if you don't confuse those 3 and start mixing them all together, you have a much better outcome.
Interesting. And is this something for people to start, 3 days post-surgery, 4 days? When do they usually get going?
Oh, right away. The range, right away. That was one of the things that, with the Jordan Young, we had they had pre-surgical education, 1, right? You don't want to educate them about their rehab recovery process when they have opioids flowing through their mind. Okay?
Right.
Because they're going to be a lot less. I mean, it's just like that doesn't, you shouldn't have that be the first time they hear what they're going to be doing. So the pre-surgical education was important. Then the hospital would push to get range of motion. And again, that was something I found when I went around, that a lot of these hospitals were just, hey, can you go up the stairs? Can you get in out of bed? You're going home. And they never bend them in the hospital because it's I don't know, they don't have the resources. I don't know why they don't. It's not good practice. I mean, they should be bending right away. Back in the old days, right, I call that, they were, you have to get to 90 before you can go home. So when they get that early push, then they would fall back when they went on, oral pain meds. They would fall back a little bit. So I usually see them, getting them at maybe mid-80s. We certainly had some bad cases, but a lot of them might have been mid-80s by the time I get them, and then we move on from there. Like there's a little bed program that's a basic strengthening program, okay, that you're doing along with it. But if I find that they can't make progress, I just say, okay, stop whatever that other stuff is and only focus on range until you get this thing moving, because quite honestly, that's usually the hardest part of what you're going to do. It's relatively easy to build strength back in the knee, but that getting that range of motion early is the bugger. And if I can get them to take their pain meds, get through that range, then everything else goes a lot easier.
There's also a lot of evidence to suggest, and I've witnessed it firsthand, where building strength has to follow at least halfway decent range of motion. And if you get range of motion, you can then get to strengthening, and you're going to do a lot better. I've seen some research, and I've seen it sort of in practice. Well, so this was in 2012. You published that book. It's on Amazon now for those who want to consume this. Fast Track Your Recovery from a Total Knee Replacement. And that's a moment in time for you, I guess, right? I mean, is that the beginning of you kind of starting to put your own stuff out there, would you say?
Yeah, I think, I'm not sure, I can't remember actually if I think I had the blog up there for a little bit. And then part of that was just my sense that people were not getting adequate information. And that's sort of my nature. I'm trying to dig below the marketing hype for people. One of my favorite posts out there is the 501k guinea pig. And people really don't know. They think that the implants have clinical trials behind them. I don't know, have you talked to this on your show before?
I've not. No. Go ahead. Let's hear it.
Okay. All right. So, let's say, Biomed or Zimmer or Stryker comes out with the iBalance knee or the whatever their, name of their latest implant is. People, think, okay, well, they've had to have had clinical trials to allow this thing on the market. The fact is they go through a fast-track approval process called a 501k, and the FDA will say, well, it's similar to everything else on the market. But it could be changing the components. It could be changing, a critical part of the structure. And that's why you see these lawsuits, because they get out there, and then in the first maybe, 5 years is when you're going to see that something maybe is wrong with that implant. Certainly you saw that with the hips, with the ceramic versus the metal, right?
Mm-hmm.
And now you see just different constructions of implants can have different failure points. And they won't know that until they get it in your knee. Start getting feedback. So that's the scary part. I always tell people to get the Honda Civic of knee replacement. Okay?
Right.
You don't want, you do not, especially if you're young, BJ, because if, God forbid, you're looking at a lengthy time in your knee anyway, and you get a bad implant, it has to be redone in 5 years. So let's say you're 50 and you have to have a redo at 55. You're looking at a third knee replacement, 15, 20 years down the road maybe, and we don't even know if they're going to last that long in younger people. By the time, with a third knee, you're looking, do we have enough bone left,
Mm-hmm.
And then the complication rate goes up, knee function goes down, the outcomes, are not as good. You really want to be really careful what you're putting in your knee. You only want a tested one.
It's funny you say that because people yell. This is so great to hear from you, by the way, and we don't talk enough about it. And I talk to knee patients all the time. And do you know what hardware is in your body? Nope, no idea. I think it might be a Dupuis. I don't know. They just, it's not part of the conversation because they're shopping for surgeons, not brands of implants when they're doing their first investigations or their friend recommended the surgeon, and it kind of never comes up. So
right.
There's a lack of exploration on that topic, I think, by patients.
Yeah, and I don't think some people try to pick the type, and I don't recommend doing that. But you do want to have that conversation with the surgeon because here's the thing: they do get compensated by these guys, right? The implant companies. So they're on I don't know what it's not like a retainer fee, but it's, consulting fees and things like that, right? And so they're incentivized to put the new things in people's knees. And so if you're, dealing with that, the old guys and the guys with integrity will not do that because they understand that it could be their reputation, right?
Yeah.
On the line.
I think the rep can be in the operating theater as well for the implant manufacturer.
Oh, they definitely are in there because there's so many different, there'll be different equipment to put them in or pull them, and they do have to give them some. My cousin's actually a rep for spinal parts, so
really?
they're definitely in there with them so that they can kind of advise them on any different changes and things for that particular model.
Interesting. So all of this work, though, it really led, and I'm glad we had that chat about your book and about the recovery program, but kind of led you to try to preempt all of this with your work, I think, which is a natural knee rescue, let's see if we can just avoid you needing to go to surgery. And maybe I'm overstating it. I don't want to put words in your mouth. So it might be avoid, or maybe it's, put off for as long as possible, the need for surgery.
Well, it's avoid and put off. Here's the thing, right? More and more, I was just actually being alarmed at the growing number of people getting early knee replacements and having it be like, oh, yeah, I'm just going to get this at 50, no problem. I mean, I think there are, again, a lot of, we just talked about this implant issue. We haven't talked about, the trajectory of demographics, right? We have the baby boomers tripping into 65 and over. There's 750,000 of these being done right now, scheduled to double, in a few years. So you're talking about more initial surgeries and more revisions. And then you have to say, as a society, right now, already total knees are one of the highest Medicare expenditures. So where is the money going to come from when we double these? You're just putting yourself in a real dependent track down the road. You see what I'm saying? I'm a more, I don't want to be dependent on something if I can possibly avoid that, right? And so people are just kind of willingly hopping on this train going, oh, yeah. And then, the marketing claim is that they're going to last, 20, 25 years. And that's all those numbers are based on 70 and 80-year-olds. We don't have numbers. Mm-hmm. In fact, the numbers we do have are kind of scary. So, like, 5-year revision rates for people under, I think the cutoff is 60. Over 60, it's like we have a 95% survival rate, which is what they say, in people over 65, let's say, all right? So that means only 2% of people need revisions in 5 years. Oh, that's pretty good, right? Well, that drops if you're under 60 or 65. I forget what the cutoff is. That drops by 5% the first 5 years. So it's now a 93% survival rate. Mm-hmm. Which, if you extrapolate that out, there'll be a much lower long-term survival rate in the younger patients because they're way more active.
Right.
Right. Yeah.
And the demographics you're talking about are trending toward younger knee replacements, right?
Yeah. I mean, more and more people. I mean, that's the largest category of people having knee replacements. And then I got into a lot of the research, and I started finding out something that I tell people that, chronic knee pain is like a check engine light on your body dashboard.
That's cool.
Okay?
Yeah.
So we find that there's people who have OA, osteoarthritis, have a 38% increased risk of cardiovascular disease, 55% increased risk of all-cause mortality, 95% increased risk of diabetes, 128% increased risk of cancer. So those are some kind of alarming.
And tell me this, it's very alarming, but is this because of the lack of mobility? Is that where this is headed, where you're going to have all these other potential comorbidities or conditions because you can't move because of the OA?
Right.
Is that what we're saying?
Right. Now that's right. That would be, you could make that correlation if we were only talking about cardiovascular disease. But when you start talking about cancer, what's going on there?
Yeah, I don't.
Right. That's really head scratching. It's like 128% increased risk of cancer. So what you find out, and there's really some good studies. There's elevated C-reactive protein, and so C-reactive protein is an inflammatory marker that your liver secretes in the presence of increased cytokines. So if what we know is that normal people have C-reactive protein levels under 6. Rheumatoid arthritis, which we know as an inflammatory disease, are higher up the chain, okay? The numbers are quite elevated. But what they found is that in a certain kind of phenotype of osteoarthritis, C-reactive proteins are from like 6 to 11. So they're slightly elevated. And that's a really, so now when we knew that, the first study to find that out, and then secondly, is that elevated C-reactive protein will predict progression of knee OA.
Right.
Which is phenomenal, right?
Right.
So
huge.
Wow. So why wouldn't I want to know my C-reactive protein level?
And is it CRP? Do they actually call it CRP? C-reactive protein? Yeah.
Right.
And so yeah, it sounds like from what you're saying, we want to know our CRP level, right? That's something that we want to know if we're
right,
in our 40s or early 50s.
Yeah, absolutely. So maybe some of your pain is related to your high inflammation levels driving this early degeneration of your knee. Okay, and then I have a great study that it's from 2018, and it basically talks about the same factors that there's 4 inflammatory factors: LOX1 receptor, CRP, interleukin-6, and reactive oxidative species. Okay, those 4 inflammatory markers have been implicated in knee degeneration, as well as cardiovascular and cerebrovascular problems. So those same markers that are affecting your knee are affecting your heart and affecting your brain.
Wow.
Yeah, and that's 2008. So it's 2018. That research is, it's state of the art. They're connecting the dots on these things, and they're looking at the same sort of, factors that are influencing a lot of these chronic degenerative conditions that are really exploding.
And are we able to get readings? Can we get these tests done? Is it a trick to do that?
Yeah, no, C-reactive protein, you can of course ask your doctor, but you can actually, they do direct labs now, except for like 3 states. I know New York is one of them that they do not allow you to order your own labs. In New York, I think it's Rhode Island, maybe Massachusetts is the 3rd one. So there's 3 states that cannot do this. You have to go through your doctor. But everybody else in the country can go on a lab, online lab company and order C-reactive protein. It's maybe $30 and get that test.
Now, Michelle, this is so great to have on the podcast. Have you written about this? Is there a blog that you've written about this particular thing by any chance?
I started a book, Chronic Knee Pain, a wake-up call, not a prescription for surgery. And I've been putting most of my efforts into that and blogging. My blog is more on the knee replacement recovery, and I feel bad. I just haven't had time to get it out there. So I've been doing some video content, and I will be blogging more on it. So,
well, let me know when you do, because I'd like to make my audience highly aware of what you're writing, because it seems like, you speak with a lot of people that are younger, facing a knee replacement, and I don't think that they feel they've got much of an alternative. Oh, I'm just going to do it. It's just, darn it, it's time. And so they dive right in, and without some of the thinking that, they might have had indicators like you're describing. There might be alternatives, just physically and diet that you can take, which we'll talk about. But there's maybe a knee-jerk reaction to knee pain, and suddenly they find themselves in the operating room. And I think that you're setting us up for a lot more exploration prior to that decision, really. Right.
And you know what, PJ, here's the thing. Here's what I think is one of the problems with this, and why people tend to gravitate that way, is because of that model, or that idea, that theoretical model that osteoarthritis is wear and tear. So if my knee is like a brake pad, right, and it's worn out, once your brake pad is worn out, what do? You go to the service guy and you get a new one, right? And so, but if it's inflammatory and there's conditions circulating around my knee causing it to degenerate earlier, then it's a completely different idea. And really, the research bears a lot of this out. They even did, so I wasn't so sure about helping people who had, joint injury. Now, because, you're specifically making the joint more unstable, right? You've had some intervention there. But there's even some research, some early research on, like, when they do mouse models where they kind of traumatize the knee, they do some injury to it, and then they put it in an inflammatory state, and they see a greater progression of that knee OA, from an injury even. Mm-hmm. So there may be hope both ways. Like the traditional inflammatory phenotype of OA, PJ, would be more related to somebody who hasn't had an injury, who has pain in both of their knees, because remember, it's systemic, right? That inflammation isn't going to affect one knee more than the other knee. Mm-hmm. And so, you've got somebody with both knees hurting them, and they're maybe, kind of younger, and they don't know why. And, but there is evidence as well to suggest that even people with injury in an inflammatory environment might progress that OA faster than somebody that doesn't have an inflammatory environment. Mm-hmm. Does it make sense?
Okay, so this is, totally
we kind of need it. Yeah, another thing that we kind of really need to get to here in this whole understanding, or maybe breaking down some maybe common misconceptions, is the idea of imaging studies and what they can actually tell people. Have you guys talked about that at all in your?
No. Gosh, this is good. Keep going. Love it.
So, and I just interviewed 2 orthopedic guys. One's a regular orthopedic guy that does total knees, but he also does stem cell stuff, and another guy's mainly stem cells now. And they both said the same thing, right? And we know this. There's a lot of research. We've done tons of research, okay, that what you're looking at when you're looking at a knee imaging study is not predictive of the person's pain. Okay? So like this orthopedic guy said, yeah, I have this triathlon guy. He looks terrible on x-rays, but he's still doing triathlons and has minimal pain. Right? And then you see somebody else whose radiograph is not that bad, and they're just miserable and say they need a knee replacement. Okay? So they don't correlate well. And again, they've done studies. Well, they'll pull people off the streets with, let's say, they don't have any problem with their back. They'll take x-rays, and these people look like they're walking around with disc problems, full-blown disc problems. So, and that is really one of the, because people just lock onto that. They go like, well, that is the reason for my pain, and therefore I need a knee replacement. The doctor said I'm bone on bone, and therefore, everything follows from that. And there was there's a famous surgeon. His name is Dr. James Andrews. He actually did. I'm a big Buffalo Bills fan, right? He actually looked at Josh Allen's Tommy John injury last year on his elbow. Okay, and he did an informal study, and he took Major League Baseball pitchers that were, active, and he had MRIs taken. He had a non-partial observer read them, and like 90% of them or more had rotator cuff injuries, according to that observer, and like 80% had labrum tears. He's famously quoted in the New York Times in like 2014, so this is fairly recent, as saying, if you want to do a shoulder surgery, take an MRI. Which is phenomenal, right? So they don't. There's, the body can repair itself. In other words, where it looks injured, but it isn't contributing to pain and dysfunction in the body.
I've come across this one-on-one with a patient who did both knees, and one seemed to really be in trouble and he was having some issues, and the other wasn't. But he said, I'm kind of older, and my doctor said it's going to be a problem, so I'm just going to do it. So he didn't. It wasn't a terrible story in the. This is a few years ago. His name is Vic. Good, lovely man. But he did both and recovered, and and went hiking soon afterwards. But I always wondered, did he really need that second knee to be done? He did it, but it was kind of curious that he would just decide that it feels fine, but I guess I'm going to go do it. Was his thing.
Never. That's my advice. Never. If you're not symptomatic, do not get a knee replacement ever. I don't care if they say, well, you're going to need one in 2 years. No. Absolutely not.
I love your bias.
There's a thing called.
I agree with you.
There's actually a thing called a Caldron-Lawrence score.
Caldron-Lawrence. Have not. Let's hear about it.
And traditionally, you had to have a Caldron Lawrence of 3 or 4 to kind of qualify. That was sort of one of the, it demonstrated that you were actually, in fact, end stage, and this was an appropriate intervention for you, right? And so I just asked this orthopedic because it's been, it's come up in my research and stuff and in my own thinking. So I'm wondering, I wonder if they're even using these Caldron Lawrence scores anymore. And he said so to me, really. He's just like, I don't treat the test, I treat the person. So the person complains enough that the knee hurts and they want it, they'll go ahead and do it. But now some of the research is suggesting that people who get early knee replacements when their Caldron Lawrence score is only a 1 or a 2 are more unhappy with the results and can tend to have lingering pain. In fact, they did research for this one guy's practice, and they took all the knees that were still having problems after a year, and they ruled out people who actually had clinical problems like loosening or an infection, and then they were left with about 40 people. And of those 40 people, they went back and had an observer look at their pre-surgical x-rays, and half of those were Caldron Lawrence 1 or 2. And they had these were people who they weren't happy, their knee still hurt, and they, their knee OA, according to the Caldron Lawrence score, was only a 1 or a 2.
And explain that to us. A 1 or the 2 means that it's not suggestive of major problems?
Very mild.
How does that feel? Very mild. Okay.
Degenerative changes. So you might see some osteophytes. You may see some minor joint space narrowing. They're looking for certain little things, and so 1 is just starting. 2 is a little bit more, and then 3 is like you're really starting to see some changes, and 4 is full blown. Boy, the joint's really looking crummy from an X-ray standpoint.
So mild cases. Now, and it seems to me, as we head towards some of the work that you're doing, I do want to get to the things that you do, natural knee rescue specifically, is those might be the people that you're really anxious to get your hands on. You, Michelle, with what you do.
Oh,
because,
absolutely.
Right? Like target on their back, talk to Michelle, set up a consultation. Right?
Absolutely. Because I think, if it were me, I would absolutely give your knee, a chance. I mean, at the very least, you're going to give it a 30-day test, a 30-day anti-inflammatory test. You know what I mean? And see if you can move the dial in any way. And, but, it's going to take a little time, right? Most chronic diseases are, result of, maybe 1 or 2 decades of problems internally, homeostatic problems that are, sort of subterranean according to the medical model, right? Which brings us to sort of that blood chemistry test that you can take and sort of identify some things. But I don't know if I'm jumping the gun if you want to, talk about the main program first. But,
Well, it's funny. I'm thinking about...
Basically, you don't just wake up with osteoarthritis one day.
Right.
You know what I mean? And same thing with heart disease. It's decades in the making, but our medical system doesn't promote finding out underlying dysfunctions that are predisposing you to disease down the road. They're really good at saying, you've got disease, but not very good at intervening at any point prior to that.
I'd like to take this opportunity with this interview with you to, when we finally publish a blog version in addition to the podcast, and of course in the podcast description, the links to these places, to understand the Caldron Lawrence, to understand the CRP test, and any other assessment evaluations that we could, that you already have the links, but I'd like to include those so that the listeners can go, while they're listening, poke around and maybe decide to go forward with the test themselves.
Yeah, that would be awesome.
Yeah, we should do that. I mean, of course, this should percolate throughout your work. I'm sure it does with the blogs that you write. And I haven't read enough of your writing, a little, but not enough. And I'm excited to go back. I really am. And it'd be fun for me to, in the various forums that I have out there on Facebook to share the work that you're doing. It's really you know what I like about what you're doing is it's not medical speak. I mean, yes, there's some technical things here, and you are crossing into some medical terms that I had not heard of before, but you're really explaining them to a layman, me, and I think those that are listening very well. It's fun to listen to you talk because you kind of get it, from what your descriptions are.
Right? If they go to that BoneSmart and they jump into that thread there, and that under 40 thread, and everybody's saying, "Hey, go for it." I just think really you got to think through this some more, right? There's a lot of other considerations for you to make a really good choice for yourself.
Yeah, and we talked about that because you've got a concern over those forums and maybe where they're funded or what the dialogue is. And I have to be honest, I have a number of private Facebook discussion groups that I've created, and there's a bias that you'll see. For instance, the one that's growing the most is about bilateral knee replacement and recovery. And I asked recently, hey, if you were to do it again, would you do both knees? And it was 100%. Everybody, absolutely, do it again. And I was wondering, okay, well, maybe they really are all happy with their bilateral, but it also might be that, they made a decision and they want everyone to know that they made the right decision, right? Yeah. So it's like we're just going to, whether we like it or not, we're telling it because it's too late for us. And we want everyone to believe and validate us making the right decision. So, I don't know. There's a group bias there.
Well, yeah, I wouldn't do it myself, but.
Yeah. Interesting. Okay, so let's get into the things that I observed on your website and your blog, and let's go into that first. It's totalkneereplacementrecovery.net, right? That's the right place to.
Yeah, you can actually get. I'm kind of rebranding it a little bit because I am moving into the natural knee recovery. It's just where my passion is. I went through some health issues myself, and just realized, wow, I'm really missing the boat here. And I had a good friend that was a trainer, and he taught me some stuff, and I was just like, kind of blown away that there's just the potential to really step out of, not completely out of the mainstream model, but take ownership of your health in a way that is proactive and will be really profound for you. I mean, I've been in medicine 25 years, and a lot of what I see, I don't want my life to be like. You know what I mean? I don't want to be going to 7 doctor's appointments every month. You know what I mean? And it's not a future I want for myself. So I want to do what I can to maximize my health, so I can, keep away from these chronic diseases. That look, at cancer seems to be everywhere. You know what I mean? And even these knee replacements, they're exploding, right? People are getting lots of these, and I can't, I don't believe that we're all just wearing out our knee faster than our grandparents did. They worked hard, our grandparents. And they were on their knees kneeling. They were doing laundry, washing, and raising kids, and they were moving and using those knees every day of their life. And we may be more active with exercise and sports somewhat, but a lot of times, the rest of the time, we're relatively inactive, I think, compared to them. So,
well, I think that the flip answer to that would be obesity. So but we're also heavy. That's where we're wearing the joint. 4 pounds for every pounds of pressure.
Yeah.
The whole that whole equation, and suddenly I could argue with you about that, but your point is well said. The easy answer would be obesity, but that may not really explain it. It may be that we all just have a predisposition to want a technology-based solution.
Well, here's the thing.
Solve our problem.
With obesity. Yeah, I agree with you. Yeah, that's a good point. But the obesity thing is that a lot of that visceral fat becomes an endocrine organ and releases inflammatory molecules. So there's where you have that. Okay, right? And then here's the thing that is really has researchers. It's really, I guess, when they started looking at it, is that obese people have higher rates of wrist osteoarthritis. So if you have wrist OA, it's not a loading issue. It's not a weight-bearing issue. It's not a wear and tear issue like you would at your knees. So why do obese people have higher rates of risk that way? And that's really where the researchers started, I think, that glaring kind of inconsistency. Why is that happening? What's going on here? Maybe it's inflammation.
Mm-hmm. And that, I think, finally, Michelle, let's get to your program.
Okay.
Because you know what?
There's a lot
we
to
could
talk
be distracted. I know. This is totally fun.
Yeah.
Honestly, we could go in a million directions, and I kind of want to, but let's get to what I've observed. Okay, so I downloaded the Kitchen Rescue from your website, Kitchen Rescue Pack Bundle. Now, tell me, first of all, is that something, did you create that, or is that something you just made available? What is that
part of
download?
Precision Nutrition. Precision Nutrition is an awesome program and platform, which is what I'm using with patients.
Okay.
And the difference is it's habit-based, right? So, I use my brother as an example a lot. He did Nutrisystem. He lost 50 pounds, and then he gained it back. He lost another 70 pounds and gained it back. Why? Because they have meal plans, right? And so the problem is that you never really identify things like emotional eating, your stress habits, maybe there's a lot of reasons why or your cooking skills, your repertoire. I don't know how to cook real food. So as soon as you get off those boxed and processed, packaged meals, you still have the same problems. You still have the same diet and habits that you had beforehand. So he put it all right back on. So anyways, Precision Nutrition's focus is we're gonna address those, and I think it's phenomenal. It really is an awesome program. It's about nutritional transformation, but once you get those principles, you could even use it for life transformation. So that's where those resources come from. They're really, really well done. Everything they do is well done.
I noticed. I watched the video on your site and downloaded the PDF, and so I was impressed with the program. And that's your level 2 nutrition precision coach, right? Precision.
Right.
But it seems like there were 3 focal points to the program, which is the anti-inflammatory part of this, the roadmap, daily check-ins, one-on-one coaching. But let me back up. Those are the functional attributes of the program. But who do you want to come visit you and sign up or become part of your program? And and what are the focal points of what you do?
Well, anyone that's really seeking, obviously the best choice is somebody who we spoke of earlier, has knee pain on both sides, no real specific injury that they can attribute this issue to, and that really want to avoid a knee replacement. They have to be willing to make some changes. This isn't easy. PJ, it's not a quick fix. Sometimes it's easier to take I just get the surgery and then, I'm good. But I would tell people, hey, you're cutting out that check engine light that's trying to warn you of something. Maybe you've got something down the road. You've got an unhealthy environment, and that's one of the things that I kind of preach is you can't have a healthy knee in an unhealthy environment, right? There's this, when I do a presentation, I show these fish in dirty water. And I said, now what are we going to do with that fish? He's sick, but he's in an overcrowded pond, and the water's dirty. Maybe there's some toxins and stuff like that. Should we give him a supplement? Right, and the answer is no. Well, that's kind of stupid. He's not. He needs more than a supplement. And then I show another picture. There are fish. They're swimming around. It's a clear, pristine water. The environment's better. That fish is going to do better in a better environment. We can't continue to think of our knee as some sort of isolated thing that doesn't exist in our body. Yeah.
Michelle, you are the queen of good analogies, by the way. You're really good at this. You've had a whole bunch on this call so far. I wish I could just come up with them like you do. It's impressive. It's good.
Well, I
totally get it.
Trying to relate,
it makes sense.
Yeah.
Totally.
So we're going to look at the environment. So the whole idea of this program is to say, okay, this is the thing with your knees, and to think of it as a gift and a blessing. Your knees are hurting, but let's address the whole health of your whole body, and let's concentrate our efforts toward maximizing that health and see where your knees go. And maybe your knee problem will be eliminated. And in fact, in a lot of cases, you do. So that's the person I'm looking for. What we do is we take, it's customized. So what I do is we do a basic, simple blood chemistry analysis. And the amazing thing about a simple blood chemistry is doctors, of course, have been using for years, but they use reference ranges, PJ. So a reference range is from the lab, and it's based on everybody that's taken the test. So in most cases, it's based on more sick people than healthy people, because more sick people get their labs done. Mm-hmm. And they're not optimal ranges. So we do know optimal ranges for these blood chemistry markers, and they're much tighter. And they come from these are very healthy people that the optimal ranges are. And so we can start to see sort of trends and patterns that suggest, hey, you might have some sluggish liver, right? Or you might have some gastric distress, or maybe your proteins aren't being assimilated and digested properly. Maybe you have some low stomach acid. So these are all like sort of underlying conditions that can predispose yourself to chronic disease later. These are the things you want to catch and remedy so that you don't get sick down the road. That's the initial thing. So we'll do a simple blood chemistry, take some inflammatory markers, see where you're at there, and then make some recommendations. Supplements are a part of it, but they're a supplement. If you don't make major changes in your diet and lifestyle, supplements will not help you. Supplements alone, in my opinion, right? So then you get the customized precision nutrition program, and then we bring in the exercise piece. Now, I won't bring in the exercise piece until maybe it depends on the person, right? If you're in just a large amounts of pain, then you're going to address the diet first. And, PJ, that comes from, a big study where they did randomized control trial. They did diet and exercise changes. They did diet alone and exercise alone. Okay, so diet and exercise, like we would think, did best. Both of those changes together had the most significant effect on knee function and knee pain. But what came in next? What do you think? You know where I'm going.
Diet.
Yay! Right? So diet alone changed people's pain and improved their function more than just exercise. Okay?
Yeah.
So that's where, again, that's sort of a inflammatory component, right? What's going on with the diet and exercise, or the diet that makes more changes than just the exercise? Mm-hmm. So I would start with the diet, and then we would work with range of motion. So we would restore range of motion if there's any lack in that. I use, and people can write this down, I love Robin McKenzie. He's a longtime, world-renowned physical therapist, wrote a small book called Treat Your Own Knee, like Treat Your Own Back. And so he just restores range of motion. Some of it can be for a mechanical derangement, which is like a sort of a meniscus issue. But it's good to just say, okay, let's try to get back the most range that we can if we've lost some in this process of increasing knee pain. We start there. Start with gentle exercise. Then you go to a precision nutrition program that is geared toward people who have chronic lower limb problems. So it's mostly upper extremity and hip related. So we're not asking you to do a whole bunch of squats, right? So that, and then you get coaching. You get one-on-one coaching. So you get people, me actually, looking over your program, giving you comments and feedback, touching base with you. And the precision nutrition program is a year long. So you say, wow, that's huge. But yeah, you need, if you're going to make changes that stick, you need to persist with it, and be committed to, I'm really making a lifestyle change. So there's two ways, though, that people can work with me. If they say, Michelle, I kind of got the diet and lifestyle thing down. I feel like I'm that kind of person that can implement things on my own, which is fine. There are those people out there. Then they can work with me to get some functional blood chemistry analysis done and some recommendations that way so that they can find out what underlying conditions might be there that they need to address. and then they can make their own, lifestyle changes.
I was just thinking that being a year long, that the coaching, the daily interaction, or the one-on-one calls would be absolutely crucial, because it was a great idea 3 weeks ago to do this program, but boy, I'm in the middle of my life right now, and my kids need Halloween costumes, and I'm not thinking about my program. And there's Michelle. Hey, the text or call or whatever it is. I need that to remind me why I'm doing this.
Right, and you're constantly, it's like when you want to make those changes, the goal that stays foremost in your mind is the one that gets done, right? So you're constantly having it back up, and you may forget it, and life happens, and you get a little off track, and then boom, we're back on track again. And precision nutrition is great from the standpoint of it's not a hard driving thing. It's like, how can we get just a little bit better than yesterday? How can we make a little bit better meal? Because it's not a all or nothing. There's not good bad food. How do we transition toward a little bit better each day? How do we get the skills to do that? How do we create the time? Because we focus on time management in that program as well. Because it's one thing to say, okay, you got to cook raw food, or not raw food, but cook real healthy food. Well, that takes a little bit more time and prep and planning. You can't just stop at the restaurant and get a takeout meal on the way home. So how do you integrate that in your busy lifestyle? So, all those things get addressed there. The things that really, they're roadblocks to people. And they're not something that we leave to the side and hope that you conquer on your own.
Well, it's a rare opportunity for someone signing up to get all of you in that sense, where it is you've got a lot to offer, and it can be diet, it can be inflammation, it's obviously exercise, and then there's just prioritization. And this is for you, and you've made a decision. You're going to take a year. You're going to focus on part of your day. You're going to focus some time on you and your health and wellness, etc. And you've got an opportunity to make that big change. And they decided upon your program and not a different program, right? Or to try to do it on their own, which is perilous. And you mentioned your brother, which is that rubber banding, going back and forth, up and down, and that's so common for so many people. So it sounds very productive. A lot of weight loss from. Yeah. Yeah. So let's go through what's the best way for someone to engage with you? How do they get to you?
Yeah, the easiest way is I have a URL called meetmichellept.com.
Got it.
So it's meetmichellept.com, and it goes right to a Calendly page where they can sign up to talk to me. I'm a human being, and that's the best way to decide if it's I'll hear your situation and maybe what you've tried in the past, and what your goal is, and then you can see if it's a good fit for you. And again, there might be some people that just want to do a functional blood chemistry, half year or maybe even quarterly to kind of keep track of those inflammatory markers. I actually have some customized lab panels created with Ultra Labs that people can get more full blown type, really in-depth look at their chemistries, inflammatory markers, or they can get and there's a lot to be learned from a simple blood chemistry stuff. So there's the gamut there, and then but just talk to me, because I can then we can figure out what might be good for you and what would be the best path.
That's great. And then I'll share links, of course, in the blog and the podcast. And the show notes and all that stuff, so it'll be easy for someone to who's listening to this, click in and go schedule an appointment with you. Then there's the book, of course, that we referred to a couple times, Fast Track to Recovery from a Total Knee Replacement. That is on Amazon, probably other places, but that's an easy one to understand that protocol that you developed way back when, 12 years ago. I mean, no, it's not 7 years ago.
I sound ancient now, PJ.
I know, it's not that long. It's 2012.
That's okay.
But that's she's this old lady. She's so old. No, not at all.
Yeah, like eons ago, right?
Yeah, way back at 12 or whatever. That's another thing to consume and explore a little bit. And you can obviously get a sense of it by going onto Amazon and leafing through some pages, which they let you do, which is cool. And so the URL, the book, and is there anything we've left on the table? This has been really great.
No, I mean, unfortunately, like on my site, my thinking and stuff, this stuff has progressed, and all the research, and and I'm talking to different people. I'm meeting with these different surgeons, and I've actually talked to somebody in India about a protocol that he's doing, which is kind of interesting. Won't get into that, but things have been accelerating so fast that I haven't had time to really update the website with a lot of this information, unfortunately. But I'm working at trying to get some help doing that. So, really the best way to do it is to contact me and get that information, live, because it's more related to knee replacement recovery, unfortunately, my site right now. But I'm working on it. So.
Got it. You need a good virtual assistant to start.
Yes, I do.
being a little busy bee behind the scenes.
Yeah.
On this particular podcast, right, we talk to a lot of patients. We talk about equipment and gear and results, but it's all around, most of it anyways, is around the surgery, and in this case, this is going to be probably the most popular of all of the podcast episodes, because this allows us to maybe skip it or put it off at least. So I think that, this is going to stand out for our audience, and I know they're going to appreciate some of the thinking and some of the links, and hopefully they'll get on the phone with you and talk about their situation specifically. So.
Awesome.
Really cool stuff. Thanks, Michelle. I really appreciate you being here.
PJ, thank you so much for having me. It was a pleasure.
We'd like to thank a few friends of the Bee's Knees podcast, including the Knee Pain Guru, natural solutions for chronic knee pain without drugs, shots, surgery, or painful physical therapy. For more info, visit thekneepainguru.com. We're also brought to you by X10 Therapy. And special thanks to Dr. Justin Trosclair at the podcast, A Doctor's Perspective Podcast.
I'm Dr. Justin Trosclair, host of two-time Podcast Awards nominated A Doctor's Perspective Podcast. I interview doctors in and out of my profession about their specialties and the occasional non-doctor special guests. But we also go behind the curtain and see what's working for their marketing, overcoming struggles, practical knowledge, book choices, and relationship advice. Join me on any podcast app on your phone, or visit adoctorsperspective.net for the show notes pages and free resources. I want you to have an abundant home life as well as a thriving practice. So come on, take a listen.
The Bee's Knees podcast comes to you from our studio in Lower Manhattan, New York City. We're here week in and week out, shedding light on all aspects of knee surgery and recovery. To reach us, send an email to thebeeskneespodcast@gmail.com.